my talk today is looking at how culture and being competent, culturally competent, really enhances health communication. In particular, looking at my PhD research. So before we go into the whole research and the question of culture, it's interesting to kind of discuss the word culture itself, because I mean, culture is literally one or two of the most complicated words in English language, as a lot of academics have been saying. So there's different interpretations of culture. So Brian Street says that culture is a verb because it's something that you create. And then you have Hofstede, which is one of the most well-known academics around culture, where he states that it's a software of the mind. It's like our mental programming. So as you can see, there's not really one definition of culture. It's quite complicated. However, nowadays, most academics kind of consider it as something that people, not just something that they have, but it's something that they create. And therefore, it kind of shows that it's a dynamic and changing and an evolving concept. So, like I said, there's no real definitive answer to what culture means, as well as how it's formed. So you have loads of different influences. You have the language, religion, gender, social economic status. You have music and arts. So quite a few elements form this culture. But the most important thing is that culture actually informs health beliefs and attitudes and behaviors. So it is important for us to keep that in mind and to kind of apply it when we're looking at health communications. So my particular study looks at understanding the gender and religious context of women in HIV in Libya. And it's a mixed method study. So I focused on gender and religion because in this particular case, those were the strongest influence in Libya and in many countries, to be honest. So it is something that is quite relevant. So in case you're unfamiliar with Libya, Libya is a country in North Africa, and capital city is Tripoli, and it's a very small population of around 6.4 million people, and it's just here between Egypt and Algeria. Majority of the population is Arabic and Amazigh origins, and the major religion is Islam, and the language is Arabic. So when we're looking at HIV in the Middle East and North Africa, because Libya sits within the Middle East and North Africa kind of geographical positioning, the overall, although the prevalence is quite low in Middle East and North Africa compared to globally, it is an emerging epidemic, and it is increasing over time, especially amongst those who inject drugs. And in particular in Morocco, and in my case, for my study in Libya. So in one of the studies that was found that Libya had the 80% of those who inject drugs in Libya have acquired HIV. So it's a massive amount. So it is a problem in Libya. And then what it's also showing, studies are showing also that there is an increase among women in the Middle East and North Africa, and again, in particular in Libya, because basically most of them are acquiring it through unprotected sex with their husbands. So just to give you a background with HIV in Libya, HIV became a concern in the late 80s when we had an epidemic, an HIV epidemic in Benghazi, where 400 children acquired HIV through blood products. So that's how it really originally started. But then now there is kind of increased trend towards sexual transmission with women living with HIV. So the HIV prevalence is quite low. It's only 0.2%. There's about 10,600 known cases. Again, like I said, it's the HIV prevalence is among people, those who inject drugs. However, it is, like I said, indicating towards sexual transmission. Now we have to be very careful with these numbers, because Libya doesn't really have the best surveillance and management systems in place to measure these numbers, and also that we are currently going through an ongoing political unrest and fighting in the country itself. So there is obviously going to be an impact on the prevalence, as well as just the management and the actual numbers. So these are just to give you an indication of the prevalence in Libya. So the aims and objectives of my study was to kind of explore the level of knowledge, the risk perception, and the risk of prejudice towards people living with HIV amongst Libyan women. And then I also wanted to look at the impact of the socio-cultural, economical, and political religious factors towards the knowledge and the risk perception, and also to understand how and where women access health information. And then look at whether age, the level of education, location influence these levels, the levels of prejudice and the level of knowledge and risk perception. And then basically speak to healthcare professionals and kind of ask them these questions and see what their responses are to my survey, which is the first thing that I did. So this is to give you an overall of all the kind of activities that I've done in order to answer my questions, which I started off with looking at the HIV epidemic in Libya. Then I looked at the challenges in reaching Libyan women. And then one of the most important factors for me was condom use, because the WHO and the United Nations, they keep coming up with these mandates saying that you should, the countries should increase investments in condoms because they're, quite cheap and they're effective. But then they really didn't understand how condoms are being used in the Middle East and North Africa. So I decided to do a systematic review on that to have a better understanding of condom use in the region. Again, because Islam, the religion, plays a huge part in the daily lives of Libyans in particular. So I wrote a paper about Islamic perspectives of HIV. And then, like I said, we still have an ongoing political conflict and unrest in Libya since 2011, where we had our revolution. So, we looked at the impact of HIV, we looked at the impact of conflict. And again, with that, I did a survey that was an anonymous survey that was sent to Libyan women living in Libya. I had over 1,500 respondents, but then I used 1,101, which were complete surveys across Libya. It was fantastic, actually. I enjoyed the whole process so much. And with that, I set up a Facebook page where women were able to have a safe space to communicate. And that was just so great to see them talking and asking questions. And so that was an amazing experience. And then the second thing is what I did is then I had semi-structured interviews with key stakeholders. And through Facebook, I got to know a woman living with HIV. And so I, invited her into the conversation as well and really got a lot of information out of her. I also spoke to academics. I spoke to a dentist, and the reason why a dentist came in is because within the surveys, they blamed dentistry. They said it was the dentist's fault that there was an increase of HIV in Libya. And obviously a gynecologist, and then I also had a senior staff member of the National Center of Disease Control as well, who was able to kind of answer a few of my questions. So in general, I had the literature review, and the literature review says that Libyans' attitude is really determined by social stigma and traditional values. It's nothing new really in the region. It tends to be that. Obviously, there's very little research. And then, like I said, the condom promotion, it needs to incorporate gender-based power and relationships and the influence of religion, because that wasn't really there with any of the promotions that are happening for condoms. There's obviously need to be more investment for women-led initiatives, and Islam remains the most influential factor in the lives of Muslims, especially in Libya. So really anything that we kind of do has to be rooted in Islamic teaching and involve the religious leader, who, by the way, refused to be involved. So that's one focus that really people need to discuss. And then again, particularly in Libya, we have the conflict. And I think one of the key issues that we need to focus on, well, Libya needs to focus on, is the potential impact of the post-conflict. Because during the conflict now, there was an increase in drug use, deterioration of the health system, as well as there's just change in the social structures as well. So women's roles have changed. The freedom that the people have is different. So these are the kind of things that need to be considered as a response to the conflict. So through my quantitative, so in my quantitative, I had the survey, but then I always had I had a box where women can add their comments or their views or questions or feedback on the survey itself. And what came out of that was actually extremely interesting, because it just came out that most of the women, they understood the burden of HIV, but they had these misconceptions. And one of them was, like I said, that they were saying that most of the transmissions is HIV transmissions came through dental work. But I think for me, the most distressing factor was these were women that I was, surveying and asking questions, and they were blaming other women for the prevalence of HIV. Again, it really, I think, ties back to patriarchal society and all of that comes with it. But I think that for me was quite disappointing. They blamed the moral corruption of women in Libya. But encouragingly, the attitude towards people living with HIV were very positive. But then again, like I said, they talked about the lack of, they talked about the lack of information. They talked about the fact that Libya just works on stigma and ignorance. And then again, through literally every single line, there was some reference to Islam. There was some reference to religion. Again, kind of pushing the idea that religion plays a huge part in the Libyan society. So for the qualitative, when I spoke to the, I can't see what this is, when I did the qualitative and I spoke to the various stakeholders, they were basically saying that, that they do blame the dentist because they don't want to accept that HIV can be acquired from other means, such as sexual relationships, such as drug abuse, they don't want to admit that. They want to live in this bubble where they say that it's the dentist and the barbers. And so obviously, again, the stakeholders reaffirmed that, yeah, injectable drugs is the biggest problem. However, what was really interesting that came out of it also is that there was a difference between sinners and innocent victims. So this came from the woman living with HIV, where she kind of made this very distinct difference and between her, because her story was she acquired HIV through her child, because her child was one of the babies that acquired HIV during the breakout in 1988. So that's how she acquired HIV. So she was very adamant to tell me that she's different from the rest of the people who acquired HIV through drugs or sexual relations or any other way, because she was kind of the innocent victim, whereas the rest of them were morally corrupt and sinners. So there was a really interesting kind of dynamic that was going there, where it was us versus them. And I discussed that later, I discussed it in detail in my thesis itself. And then obviously it's just a lack of communication, lack of awareness. But most of all is that women have no agency. They have no choice. So when I spoke to the dentist and we were talking about HIV situation in Libya, and she told me, she said, what do you want the women to do? And I said, what do you mean? She goes, well, say, for example, she was married and she got HIV from her husband. What do you want her to do? Nothing. There's nothing she can do. So that came up as a huge thing of agency and choice. So basically, when I started this research project, my initial focus was on prevention. And I just wanted to kind of think of ways of how we can, use communication to prevent HIV, the virus, to create awareness. And that's what was my initial thought. However, through this whole process, through this whole research, I've realized that there's no point in looking at prevention and working on prevention when the women have no agency. A woman cannot really go to her husband and say to him, I suspect that, you've been unfaithful, or I suspect this, or, I need you to wear a condom, or they have no ability to do that. So by me creating an awareness campaign, of how to keep yourself safe, it's actually ineffective. It's not going to really make a difference. So really the focus needs to be on accessing service and management. that's where the focus of the communication for women should be. It should be looking at explaining to them that there are treatments that are available, because if you are on ART, it will reduce your viral load and it will be untransmissible, which is then the U equals U message, which is undetectable equals untransmissible. And it's and I think this message is so important, because not only does it counteract the stigma, because most of the stigma comes from not knowing. It's most of it, people are scared of contracting it. So it's important to kind of discuss the accessing of services and management. And I'll give you an example of U equals U, and the impact of it was when I speak to my family members, Libyan family members, at the beginning of my PhD journey. I asked them, for example, like, if you knew that this person, he's a shopkeeper and he had HIV, would you buy their produce? Like, would you buy products from them? And the majority said, no, we would literally cross the road so that we don't even walk in front of their shop. But then 3-4 years down the line, they've come with me in this research journey. And I've explained to them that it is not transmittable in this way. I've given them the information. They've heard the stories. And now, the last time I asked one of my family members, and they said we would eat from the same bowl as a person with HIV. So it's that that's what shows you that, okay, it's not, maybe the focus shouldn't really be about prevention to women. It should be about acceptance, about that there are ways that you can manage this. And using religion, using the influence and the involvement of religious leaders, using the fact that there's part of the religion, yes, there's a lot of people who say, yes, but they've done this and they've done that, and that's why they have HIV. But that's, as Muslims, because obviously I'm talking about Islam, as Muslims, we are not supposed to, well, I mean, all religions, to be honest with you, we're not supposed to judge other people. So we need to act as good people, good human beings. And that's what it says in every single religion. So it's really to use the religious leaders. For them, they don't have to they don't have to promote condoms. This is one of the issues that the religious leaders don't want to get involved, because they say that if we involve condoms, if we talk about preventative methods, we are encouraging, in kind of immoral actions of sex out of marriage. We're encouraging this kind of behavior, but not really. Because at the end of the day, it is happening, regardless of what anybody's saying, it is happening. So the religious leaders need to come in from the other side. They need to come in really emphasizing empathy and tolerance and acceptance and repentance. And I think all of those things would actually make more of a difference. And then also we need to work within the existing culture and social practices. And the reason why I focus on this is because, again, when I was doing this research, I saw a lot about what the UN was doing, or what the UN was recommending, or what the WHO was recommending. And it doesn't fit within our social and cultural practices. It just doesn't fit in it. One of the examples was that in my survey, like 33% of the women did not know they had taken an HIV test. Now, considering that HIV testing in Libya is mandatory for certain employment and for marriage and for children, and these are married women. I specifically targeted married women. How could 33% of the women have stated that they have not taken an HIV test? They must have. So when I spoke to the healthcare providers and the academics, and I asked them this question, and most of them said probably because they didn't know. They didn't know they had an HIV test. All they know is they had a blood test. So that goes back to WHO. They've recommended an opt-out option. So you're automatically opted into an HIV test, regardless of you knowing or not. And this causes a huge ethical dilemma in countries like Libya, because you don't know the repercussions of a woman finding out she has HIV. And you've taken away this ability for her to make a decision. And I think this is where you have to look at culture and social practices and how it works within your healthcare communication. So this is why I'm very keen, and I love this framework, which is called the culture-centered approach. It's It's an amazing framework. And basically what it talks about, it tells you the difference between being culturally sensitive and using a culture-centered approach. So being culturally sensitive is basically health communication using concept of culture to become more effective. So if you're going to use preventative methods, you would just kind of maybe do it in Arabic, or you would, use, traditional folk tales to discuss some sort of prevention. Whereas with the culture-centered one, what it looks at is it looks at the actual meanings of in that country, and uses the people to create a dialogue with them and understand what is the problem. And really what it does, it questions, which is the most important thing, it questions the taken for granted values of Western knowledge. So instead of, for example, promoting condoms, why are we not promoting abstinence, right? In cultures like Libya, this is something that's very acceptable. So why are we not doing that? Why are we focusing on certain things that are really considered to be very Western? And what it does with culture-centered approach, it looks at culture, it looks at structure, and it looks at agency, and it looks at the interaction of them, of all three together. So, you can do something. You can say, for example, well, women can insist on wearing condoms. Well, no, but they don't have the agency for that. But we don't have the structure. There's a structure within the country to support certain things. So it kind of looks at all of that. So when you approach any healthcare communications an issue or initiative that you want to do, you need to look at how those three really work together for it to be effective. And essentially and ultimately, what this approach does, it looks at the possibility of social change through communication. And that's really what it is that I want to do. So some practical strategies, in case anybody's interested in applying this, is to shift your role from being a researcher who plans and executes campaigns to being someone who listens and participates with the community. And I actually fell into that as well, because I originally was like, no, I want to do a prevention campaign, and I'm going to make it in the dialect, and I want to use Libyan this and Libyan terms. And then I realized that actually I'm not really listening to what they're saying. I'm just coming in with my preconceptions and my ideas and saying that this is how it's going to be. And I am coming in with this bias because I grew up in the UK. I've been educated in the UK, and also I've been following the UN, following the WHO for their recommendations, and I've come with these certain ideas and saying, well, we can apply it, but we just need to kind of make it more culturally relevant. No, it's not really the case. You need to really understand the health issues and the meanings and the experiences of those health issues. When you're speaking to somebody like a woman living with HIV in Libya, the experiences that she had are the ones that should be guiding it, because all she said most of the interview was that she just wants to be accepted. She just wants to be treated with kindness. Because her acquiring HIV was something that she accepted as part of faith. Like, this is her faith, this is her fate, this is something that was written for her. But she just wanted to be able to be accepted and go to a wedding and not have people not share the food with her. So again, to also understand the challenges of the community and what is available to that community and what's not available to that community. It's great to say, oh, but you should use personal stories, which is one of the most effective ways of interventions communication, is using personal stories. And yeah, but you can't do that in Libya because the repercussions are too great to do that. So so basically using also culturally appropriate communication tools and channels to reach them and to inform them. Looking at, for my research, we found that online works the best. Okay, I think most of the countries, to be honest with you. But for us, it was mostly because of the privacy, that women were able to look at things that they want to look at, question things in the privacy of their own home and their own phone. They didn't have to, nobody had to know what they were looking at. So that's basically my study. And so here are some references, and then also some of the papers that I had published. And that's it.